I think with that, we'll start the meeting. So, hi everyone online and in person, and welcome to the TIA Centre seminar. So, for those of you that are new to our seminars, in these seminars we aim to invite researchers from across the globe to present new and exciting work. And today I'd like to introduce Dr. Hanya Mahmood. Dr. Mahmood graduated from the University of Birmingham in 2012. Following this, she completed dental foundation training and multiple dental core training posts in oral and maxillofacial surgery, medicine, pathology, and radiology in Yorkshire and the West Midlands. During this time, she obtained membership in the Faculty of Dental Surgery, qualifications in consultation, medical education, and fellowship of the Higher Education Academy. She was appointed as an NIHR, which is an academic clinical fellow / specialist registrar in oral surgery, School of Clinical Dentistry at the University of Sheffield in 2018, shortly after which she completed a Master's in Clinical Research and Diploma of Membership in Oral Surgery. She was awarded a prestigious NIHR doctoral fellowship to pursue her research under the supervision of both Professor Curran and Professor Rajput in the use of artificial intelligence to aid the early detection of oral precancers. Her current research focuses on the application of machine learning to explore novel digital markers in oral epithelial dysplasia. She's a key member of the evolving NearPath research group, leading innovation in head and neck cancer research. She's also a member of the British Dental Association's Health and Science Committee and chair of the Education Committee of the Association of British Academic Oral and Maxillofacial Surgeons. So the title of Hanya's talk today is Prediction of Malignant Transformation and Recurrence of Oral Epithelial Dysplasia using Architectural and Cytological Feature-Specific Prognostic Models. So thank you very much, Hanya, for joining us today. We're really excited to hear your talk. And yeah, feel free to start when you're ready.
Thank you. Yeah, thank you, Adam, for the really detailed introduction, and also for inviting me to present as part of the TIA Research Seminar Series. I can see that you've had some really brilliant speakers in the last months and years. So yeah, I'm really delighted to be able to contribute. As mentioned, this work forms part of my NIHR underdoctoral research fellowship, and it's predominantly looking at histological predictors of oral epithelial dysplasia, particularly with a focus on prediction of malignant transformation and recurrence. So that's what I'll be talking about today. My disclosure is NIHR. This work is being done under the supervision of Professor Rajput and Professor Ali Khurram, who's a consultant oral maxillofacial pathologist in Sheffield. Most of you at the TIA know him. And I just want to acknowledge all the co-authors as well who've contributed to this study. So starting off, I just want to talk about the clinical context of this research, really. As a clinician and as a surgeon, you know, the main drive for doing any research is to improve patient outcomes and improve patient survival. And with oral cancer specifically, we know it's a growing public global health concern. It's amongst the top 10 most common cancers in the world. It's the 14th most common cancer in the UK. And unfortunately, although there has been improvements in oncological and surgical treatments, the numbers are rising rapidly. There's more than 500,000 cases in the world every year. And in the UK alone, there's been a 58% rise in incidence rates, accounting for almost 9,000 diagnoses every year. And with that, mortality has also worsened. So there's been a 48% rise in death rates related to oral cancer in the last decade. And that's more than 3,000 deaths every year. The 10-year survival rate is low and it's variable, and it's actually lower than other common cancers, including breast, prostate, and colorectal cancer. And the survival rate is directly linked to the time of presentation and the stage and the grade of the disease at the time of diagnosis, and varies between 18 and 57%. Now, a lot of that is related to delays in presentation from a patient point of view. The State of Mouth Cancer UK report in 2022, which was published by the Oral Health Foundation, actually looked at education and awareness amongst the UK adult population and found that there was a significant lack of understanding of what the major signs and symptoms of mouth cancer are. So of course there is a delay there in presentation, and we know that there is difficulty with access to dental care as well.
So mouth, sorry, Hanya.
Yeah, sure.
just about the last slide. So you said that the incidence of oral cancer is increasing every year. So how come with say stuff like smoking, that's probably one of the main factors, right, is decreasing on average in our developed countries. Why is the rate of incidence there still increasing?
Yeah, I mean, so there have been lots of policies that have come into place, as you know, like stop smoking bans, and the risk factors have generally reduced, but cancers are evolving, and there is actually a subset of patients that develop oral pre-cancer and oral cancer that haven't been exposed to these risk factors. So clearly genetics is driving a lot of those mutational changes to develop into cancer. And actually that category of people, the people who come in with those abnormal changes in the mouth that don't smoke and have never drunk alcohol, they're the more concerning group of people, because clearly the behavior and the aggression of the lesion is not driven by the carcinogens and those risk factors. And then we also know that we have viruses, HPV, EBV, and other drivers for cancer development as well, outside of just the environmental, social risk factors as well.
Thank you.
So mouth cancer can affect any part of the mouth, you know, the lips, the cheeks, the roof of the mouth, the floor of the mouth, but the area which is usually most concerning and usually linked to the higher risk of malignancy is on the tongue. So the margins of the tongue and the base of the tongue, and usually those areas are often missed during clinical examinations, and you know, patient self-examination as well. And we've obviously just touched on some of those risk factors that are associated with mouth cancer, and also the group of patients that get it in the absence of those risk factors as well. So it can affect men and female, but in the UK, majority of patients diagnosed are male, and it has an age-related incidence as well. So more than 3 in 4 patients in the UK diagnosed with it are over the age of 55 years. So this really highlights the importance of early detection and picking up that lesion as early as you can, so the patient gets timely treatment and the best treatment for them to minimize overall side effects, morbidity, mortality, and to improve quality of life. And we know that with early detection, survival can improve from 50% to 90%. So unfortunately, a lot of the cancers or the pre-cancers that come through are detected at quite a late stage of disease, when the lesion has already progressed quite a bit, and that can have a direct influence on the prognosis and the survival of a patient. So my research focuses on the earliest possible stage of oral cancer, which is oral epithelial dysplasia, which is the precursor to oral squamous cell carcinoma. It's a chronic and progressive condition that can affect the lining of the mouth, can affect any part of the mouth, and you can see from these photos it has a variable appearance. It might present as this unexplained white lesion, a red lesion. It might have a mixed presentation, and it can arise at the margins of ulcers as well. And that's partly the reason why it is difficult to diagnose this early, because of its variation in clinical presentation. And there are no specific clinical pathological predictors with regards to which lesions are more likely to progress to cancer and which ones are more likely to come back after they've been treated. So when patients present with these lesions, we will typically biopsy the lesion and we'll send a sample to the pathologist, and conventionally they will diagnose the condition using the WHO classification for dysplasia grading. And that criteria grades the lesion into mild, moderate and severe categories based on the presence of a wide range of cytological and architectural abnormalities within the epithelium, and the extent to which they are present and the location of those features within the epithelium as well. So those black lines, if you imagine those as being invisible lines, and this is what the pathologists use to diagnose. So if the atypia is confined to the lower third of the epithelium, it's usually a mild grade. If it extends to the middle third, it's moderate grade. And if it involves the full extent, that's a severe grade. But really, this kind of dividing the epithelium into thirds really oversimplifies the complexity of this condition. And the WHO classification is associated with a number of limitations. So not only are there lots of different features that can be seen down a microscope, many of them are not poorly not well defined, and they can be ambiguous, and there are variations of these features. So it can result in interpretation differences between pathologists and subjectivity, and that results in the high inter and intra-rater variability. And very little is known about which of these features in particular, either in isolation or in combination, are important in the progression to cancer or in dysplasia recurrence after treatment. So to complicate matters kind of further, the recent update from the 5th edition of the WHO classification for head and neck tumours in the oral cavity and mobile tongue, there has actually expanded the range of histological features seen in dysplasia. So you can see, I'm not sure if you can see my cursor, the lower part of the table, they've added extra features in. So there's now 27 features in total that are looked at by a pathologist. And actually, when we presented this research very early on to a patient and public advisory panel at the School of Dentistry, and we discussed this problem with patients, one of the questions that the patient asked was, how do you know, when it comes to you developing the machine learning algorithms, how do you know which features to train the algorithms for? Which ones are the most important? Which ones are you going to start with? And it's a really good point, because this criteria is constructed on relatively low evidence base, and that's kind of led to the research that I'm doing and presenting here. So there is an alternative grading system which was proposed by Omar Kujan, known as the binary grading system, which essentially aimed to improve the reproducibility of grading between pathologies to help with and also minimize subjectivity. And it used the same histological features as that described in WHO, but graded the lesions using binary categories, low and high grade, essentially to eliminate this middle ambiguous intermediate category based on the number of architectural and cytological features. And they compared the rater agreement and the prediction to malignant transformation with WHO, and found that the sensitivity and specificity of their binary grading system that they'd proposed, both for prediction of malignant transformation and for accuracy of their system, was quite high. But they described it as above 80%, suggesting that it can actually complement the WHO classification. But more recent work, sorry?
Sorry, Hanya, can I just ask the question on the last slide? So in relation to the binary grading system, is there any specific rationale why it's 4 more or less than 4 architectural features and 5 cytological features, or is that just roughly half of the amount of features that are present?
To be honest, I'm not 100% sure from a pathology point of view why those numbers were chosen. I'd imagine it's difficult to evaluate the full range of features, and usually maybe the diagnosis is only influenced by 4 to 5 features overall. Having said that, you can still get a dysplasia diagnosis just with the severity of 1 or 2 features alone, from what I know. So yeah, it's not explained in the paper, and I'm not sure completely why they've chosen those numbers, Adam. But that's my thinking behind it.
Okay, thank you.
So a recent systematic review and meta-analysis, which actually compared the binary to the WHO system, actually highlighted that whilst the inter-rater variability may be lower in the binary system compared to WHO, there's still inconclusive evidence to demonstrate that it's a much more superior system to WHO at predicting malignant transformation. So it's not routinely used, and if it is used, it's still used in conjunction with WHO. So my study had 2 primary aims. The first was to conduct detailed histological analysis of individual features of OAD as described by the WHO criteria, to see which were most prevalent and predictive of malignant transformation and recurrence. And secondly, to develop and propose histological feature-specific prognostic models to predict outcomes. The first stage of the study involved preparation of the OAD cohort. So we had 109 H&E tissue sections, which were identified using a local pathology database at the School of Dentistry, and these were evaluated in terms of quality for inclusion. and to ensure that there was a minimum of 5-year clinical follow-up data available. And then they were converted into digital whole slide images. We had 5-year follow-up data, including basic demographic data, whether the lesion transformed, whether it recurred, and basic treatment information as well to allow prognostic correlation. And then 3 pathologists were involved in detailed histological feature-specific evaluation, and they were asked to essentially rate each feature based on its abundance and its presence, and also to identify any other features that might have been important in influencing the diagnosis. They had a general discussion about their approach to the task, but there was no formal calibration undertaken to minimize examiner bias. And then the top most common histological features as per consensus scoring were then further explored to determine observer agreement and prognostic significance, and univariate associations between individual features and clinical outcomes were also calculated using a Cox proportional hazards regression model and visualized using Kaplan-Meier survival curves. So this is the study cohort. A blind reanalysis of the cases confirmed that just under half the sample were graded as moderate and a quarter of them as severe. And on the binary grading system, 33% of those cases were graded as high-grade lesions. So the pathologists regraded these and they were blinded to the clinical outcomes. And the median age range was 67 years, and there was predominantly a male population within this cohort. And 18% of the lesions had transformed and 25% had recurred following surgical excision. The intraoral sites were variable, but majority of them came from the tongue, and that could be anywhere from the tongue, the side of the tongue, the top of the tongue, or underneath it, followed by the floor of the mouth, and the cheek, which is the buccal mucosa. So amongst the features which were analysed, basal cell hyperplasia and irregular surface keratin were shown to be the most prevalent, and a further 5 features were highlighted as having the best rater agreement. And looking at those features, I've got a couple of pictures coming up shortly, but it's not surprising that those 5 features had the best rater agreement because they're bit more obvious to my eye as a surgeon compared to some of the others. The time to cancer development and recurrence was also calculated, and there were 6 specific features which were shown to be statistically significant for both of these clinical outcomes of interest. And it was these features which were then used for development of the models. So just to show you in terms of photos what some of these features look like down a microscope, on the top I've just got some healthy images for comparison. So, and these are all little tissue sections of different dysplastic cases. So loss of stratification in the first image, it essentially just describes the disturbance of the stratified layers of the epithelium, which usually in healthy tissue would be much more organized and there'd be much more distinguished layers. And you can see that that's kind of lost in this image. And the next one, loss of epithelial cohesion, the cells are kind of broken apart and they're a bit more spaced apart, and you can see the gaps between them, whereas for typically they'd be much more neatly lined together with even spacing between them. And suprabasal mitoses, which is just essentially a mitotic figure which is present outside of the basal cell layer. This image on the bottom left shows bulbous rete processes, which is essentially, if you look at this process here, it's slightly broader at the base than at the apex, and that's a classic feature of dysplasia. And in this image here, there's quite a lot of different dysplastic features you can see. So there's nuclear pleomorphism, which is variation in the size and the shape of the nuclei beyond what you'd normally expect, and deviation of the nuclei from a circular to an oval shape, and also much darker stained cytoplasm and nuclei as well. So the 2 models which were developed and tested, the first was a 6-point model, which essentially gave a single point to each of the 6 features which were associated with the greatest incidence and risk of malignant transformation and recurrence. And the second was a slightly more simplified, reduced 2-point scoring system in which a single point was given to the 2 features which had the best inter-rater agreement and were also associated with the clinical outcomes.
Sorry, Hanya, we've just got a few questions on the chat. in
Sure.
relation to the previous slide. So Fires has asked, was there any multiple hypothesis correction done on the feature significance values shown? That's on the previous slide. And he also notes it interesting to analyse associations between these features.
What could you elaborate on that? Sorry.
On the first point, sorry, about the.
Yes, yeah.
So do you mind going to the previous slide?
Prior to these.
Yeah, sorry, prior to the images. So with these particular analyses, have the individual features been put into a Cox proportionalities model?
Yes, they have, yes.
Yeah. So I think Fires alludes to the fact that if you've done 3, 6, not 12 different analyses to get 12 different p-values, that it might potentially need some multiple hypothesis correction.
Right, okay, yeah. And these were the features which were shown to be the most prevalent on consensus scoring. So that's why we've only looked at this selection of features for further evaluation and prognostic correlation. But thank you.
Thank you.
So just fast forward. So these are the survival curves for both the 6-point and the 2-point scoring system, which I've highlighted on the top. And you can see, looking at the 6-point system, if a patient had 4 or more features, or if they scored 4 to 6 points, essentially, they were predicted to have a higher risk of malignant transformation and recurrence at 5 years than if they had fewer than that. And similarly for the 2-point model, the presence of both of those features in combination appeared to be associated with a higher probability for malignant transformation. And the prediction suggested that the presence of just the bulbous or drop-shaped Reti pegs alone had a higher predictive association with transformation and recurrence at 5 years in comparison to the presence of just loss of epithelial cohesion alone. And here are the ROC curves for transformation and recurrence based on feature count for both of the systems as well. So for the 6-point model, the sensitivity and specificity was best balanced by using a cutoff of either 4 or 5 points with less events. So with less events, fewer features were present. So the AUROCs for those respectively were 0.79 and 0.76. Sorry, the text is really small there, which is fairly good. We then evaluated the performance of these models by adding in certain clinical variables such as age and gender, and also histological grading systems as well. And adding in the the age and the gender did marginally improve the predictive ability of both models slightly, but actually adding in the WHO grade optimized the performance better. So we weren't able to really model using the clinical site categories because there were such small numbers between the different groups that it wasn't really possible to look at this. But what this does show is that the WHO grading system clearly does have still some prognostic value, which is adding to the performance of these models. And we then evaluated each model's performance against each other and against existing grading systems, and both the 6-point and the 2-point model demonstrated a higher AUC than achieved individually by the WHO or the binary system, with some significant differences noted. And then to see how things would be in clinical practice, we looked at the performance of the models. We looked at them separately for each of the 3 raters, and then based on consensus scoring as well. And both models showed slightly lower prognostic ability when it was used by a single rater. And that, I guess, indicates a greater risk of misclassification compared to if the models were used by multiple observers. And I guess this analysis does indicate that improvements on existing grading does require greater levels of agreement between assessors, which we know. So the findings of this work have identified some important new information and new insight into oral dysplasia progression. Basal cell hyperplasia and irregular surface keratin were shown to be the most prevalent features, though these weren't statistically associated with transformational recurrence. And a further 6 features were shown to be important for both of these clinical outcomes, and they're listed there, and that's what formed the 6-point scoring system. And additionally, bulbous rete pegs and loss of epithelial cohesion were also shown to be important, but had the best rate of agreement between the pathologists in this cohort. So this study has developed for the first time histological feature-specific prognostic models, which has shown good predictive ability and is also optimized by the incorporation of existing grading systems. Now, of course, the kind of main limitation of this is that it's been looked at on a single center cohort, so validation on larger independent multi-center cohorts is important with prospective analysis to assess the clinical utility of these models and to explore these features further. And since that work has been published, it has allowed us to expand the work that I'm doing. And I know it's helped Adam, you as well as part of the Anticipate work. So we are better informed with regards to the machine learning algorithms that we're going to be developing and which features are important and worth exploring with regards to cancer development. And I'm also looking at other novel histological features that are routinely seen in dysplasia, but are not routinely quantified or correlated to clinical outcomes. And that work has shown some encouraging and promising results. And we've also been able to develop a more novel model, which has shown good prediction for transformation. So that's it. I'd be very happy to take any questions from anybody in the audience.
Brilliant. Well, thank you very much, Hanya, for a really interesting talk. So first of all, any questions from the audience? I think we've got a couple of questions in the chat. So Fires has asked if these results are over the testing set or if it's based over the if it's over the entire cohort.
The findings that I've presented is just for the development set. External testing and internal testing hasn't yet been done. So that's the next stage of work.
Sure. Do you have any questions in the room? So I have one question besides that. So I noticed that transformation seems to be easier to predict, where you're getting higher synthesis. What is there any reason why you think that is?
Well, I think I guess it's to do with this being a retrospective study, collecting retrospective clinical data. It is much harder to get recurrence data for data sets because it's difficult to know whether actually the recurrence is definitely from that initial primary lesion or whether it's just due to field change from the surrounding tissue, which has changed as a result of it. So that could be one reason. And we did have a good representation of both patients who had go on to develop cancer and also had recurrence in this data set. Yeah, that's one possible reason for it.
Okay, thank you. And I also wondered why when you incorporated the WHO grade, do you mind if you go back a couple of slides?
Yeah. Doesn't seem to want to go back. Yeah, which one, sorry?
If you go back one more. Oh, that one there, sorry. Yeah, so when you include the WHO grade, you get the best results in terms of transformation and recurrence. Why do you think that is compared to, say, the binary grade, which has been shown to be more prognostic previously?
I mean, it's a marginal improvement, isn't it? The binary grade has still improved it slightly than just using our prognostic systems alone. Again, I guess it's because we know that the WHO grading system has more features that it evaluates. It's difficult to know with the binary grading system whether it's one problem with the binary grading system is that it doesn't tell you which specific features as part of the quantification are to be included. It's just a general 4 or 5 cytological architectural changes. So it's whether there are 1 or 2 specific features that are contributing more. That could be one reason. But as I say, it's fairly marginal improvement, isn't it, between the two? And what we also know from the recent work I presented with the binary grading system is, whilst it's better with reproducibility and reducing inter-rater agreement, there's still a lack of evidence to show that it is superior in terms of its prognostic prediction compared to WHO.
That makes sense, thank you.
I think it's not been validated as much on prospectively either. So there's
I suppose you've also got more, well, course of grade have got 3 grades instead of 2, which might have some prognostic. Yeah.
Possibly, yeah.
We've also got a question from Fires in the chat again. He's got a small comment, I suppose. He said it would be nice to divide the data into training tests to evaluate the significance, the improvement based on variation in AUC values. It'd also be interesting to look at the different hazard ratios of the features.
Yeah, I mean, this, I suppose moving forwards, that's probably what we ought to do really. But this was obviously just the initial early work with regards to development of the models. But yeah, that's a good point.
Right. Well, thank you very much, Hanya. I think that's it. If there's no more questions online, I suppose we'll bring the talk to a close, but that's been really interesting. So thank you for coming and doing the talk.
No, thank you for inviting me.
That's all. So just a reminder for everyone else online and in the room that we've actually rescheduled our next TIA Centre meeting with Professor Azraza. It was meant to be on the 3rd of April, but it will now be instead on Monday, the 15th of May. And instead, our next seminar will be by Paul Tournier from Nice in France on Tuesday, the 18th of April. So Paul Tournier on Tuesday, the 18th of April, Professor Azraza on the 3rd of April. Sorry, on the 15th of May. But no, thank you very much, everyone, that's came in person and online. And yeah, hope everyone has a nice rest of the day.